Now coming to monitoring. What are the various monitoring in the preoperative period? Here the baseline is your ECG, where you go for lead 2 and V5. Lead 2 is for arrhythmia because your P wave is maximum at lead 2 and V5 for ischemia, and you go with the 5 lead ECG monitoring system, and pulse oximeter is also connected. Next comes the invasive artery line. Usually it is the radial artery. If LH test is negative or the collateral circulation is not good, you go for an alternative site for radial artery cannulation. That is very, very important. Your beat to beat analysis of arterial pressure is very important in cardiac surgery. If radial artery is used as a vascular conduit for coronary artery bypass grafting, you will use the radial artery on the opposite hand. If that radial artery is not okay, you go ahead with femoral artery, either right or left femoral artery. And coming to central venous access, this is done to monitor your central venous pressure. Sometimes it can be used to give lot of volume loss, is very common in cardiac surgery, and you need a central line to push in lot of volume, transfusion therapy, and for administration of vasoactive drug. Now comes to another important question, whether you insert the central venous catheter or PA catheter before or after induction. In patient with good ventricle, ideally central line can be inserted after induction. But if the patient is sick or a poor ventricle and his heart is not functioning properly, in those cases better to have the central line or PA catheter before induction, so that you will have the baseline filling pressure. As I said earlier, placement before anesthesia induction is ideal, so that CVP can be monitored during induction of anesthesia. But also remember, in awake patient, it takes more time and discomfort and may cause unnecessary hypertension and tachycardia. So it is basically a risk-benefit analysis. Benefit is you have the filling pressure before induction, and the risk is patient might be in discomfort leading to unnecessary anxiety, sympathetic stimulation, and hypertension and tachycardia. In those cases, if at all you want to put before induction, you can give a slight small dose of midazolam and fentanyl and then insert the central line. Urinary catheterization, nasogastric tube, your transesophageal probe and temperature probe are all introduced after induction of anesthesia. So the baseline monitor includes ECG, your pulse oximetry and radial artery line. Your CVP or PA can be decided depending upon the patient whether to put before induction or after induction. And after induction, you have end-tidal carbon dioxide, which is connected to the endotracheal tube, nasogastric tube to decompress the stomach, your temperature probe monitoring. Usually, nasopharyngeal is monitored, but some team monitor the core temperature also. Then, if patient has poor LV, people keep femoral artery also ready for insertion of IABP as well as during monitoring. And if patient is going on cardiopulmonary bypass, they want to monitor the aortic as well as the peripheral pressure. In that cases, femoral artery will be inserted, and a urinary catheter to monitor the urinary output.